Let me just get this started, and there we go. It's the spinning globe of Georgia Memory Net. So today it's Stephanie Vyverberg. We're very happy to have her here. She has 18 years of experience as a nurse. She has her BSN from Harding University and her master's degree as a family nurse practitioner from Georgia State, go Panthers, in 2008. And she has been in the cognitive neurology clinic here at Emory University and Emory Healthcare for 13 years. And she is going to walk us through the long and winding road of dementia management, caring for common symptoms of Alzheimer's disease. In addition to her experience in Alzheimer's disease, she has a lot of experience with other related dementias, such as frontotemporal dementia and vascular dementia. And there's one other, Lewy body dementia, as well as a number of others. So we're really excited to have you here. And so thanks for joining us today at GM Insights, Georgia Memory Net Insights. And here's our disclosure statement. There's no significant financial interest that Ms. Vyverberg has disclosed. And there's nothing but good information for you here. You have the opportunity to apply for credits for this activity. And so thank you for registering. And let's go ahead and get started. So appreciate all of the expertise that's in the room right here. I'm Ted Johnson, and I am the primary care coordinator for educational outreach for Georgia Memory Net. And I wanted to get you started with a chat box waterfall. So what I want you to do is go ahead and type an answer into the chat, but don't hit send yet. Type an answer into the chat. What is the most common non-cognitive symptom that you see in patients with dementia in your practice or in your work? It might be sleep disturbance, anxiety or depression, agitation, delusions, hallucinations, paranoia, apathy, something like that. So go ahead and type it in, but don't hit send yet, okay? And so I'm gonna just monitor and watch the chat box. I'll give you just a couple more seconds to go ahead and type that answer in. I really appreciate that we have 26 people joining us today. So this is gonna be a rich opportunity to share some information. All right, so hit send on the count of three. Ready, 1, 2, 3. Go ahead and hit send. Perfect. All right, so we've got a number of here. Thanks so much, Mandy. Depression and anxiety. Mariama, confusion. Carolyn Clevenger, disordered sleep. I appreciate that. Anxiety, depression, agitation, urinary issues, and agitation. So confusion and wandering. Thank you, Brittany and Andrea. Lynn Hansen, losing and misplacing things. So a lot of knowledge in the room. And so if what I want you to do next is I want you to look at all the answers that people gave, thinking about the answer that you gave in terms of most common. And what I want you to do is go ahead and type into the chat, but don't hit send yet. Type into the chat, which of the above symptoms do you find the most difficult to manage? And that'll help Stephanie with kind of her presentation and thinking about the things that are commonly seen by you and bothering you. So go ahead and type in, but don't hit send yet, most difficult to manage. And then go ahead and hit send. Dr. Cohen, agitation, confusion, agitation, anxiety, wandering, sleep. Agitation. I was thinking sleep and agitation myself. That's kind of a two-way tie for me. But a lot of people thinking about agitation. And so really important. And so I'm going to turn it over to Stephanie to take us through today, her talk. And here are her objectives. Stephanie, take it away. Thanks so much for coming in and giving our session today.
Fantastic. Thanks so much, Ted. And thanks for that warm welcome and also for getting us all started with a great discussion. Hopefully we're not all agitated and sleepy now, but I too answered sleep disturbance as the thing I probably most commonly see in my clinical practice. And I find sleep and agitation to probably be the two most difficult ones to manage. And so sounds like a lot of us are on the same page. It is a long and winding road. Once someone receives a diagnosis of dementia, whether that's due to Alzheimer's disease or another related etiology, whether that's Lewy body dementia, frontotemporal, vascular, mixed bag, there's the diagnosis and then there's all the symptoms that come along with it. Today, I'm going to spend some time focusing on accompanying symptoms that aren't necessarily cognitive in nature, that are very, very commonly seen and yet present quite a challenge, especially if you don't have the luxury of 40-minute appointments like I do in a cognitive clinic, and you're in primary care or geriatrics, and you're having to roll through a number of patients with complex problems that all need to be addressed at the same time. And so we're going to spend some time talking through the most common symptoms, and also as they appear within the disease trajectory from mild to late stage disease, because that can be significant in terms of what you ask about and how you uncover and really address those symptoms. We're going to talk more about how to really readily and quickly assess for those symptoms in the outpatient setting, and also spend some time on pharmacologic and non-pharmacologic management strategies. Depression, anxiety, neuropsychiatric symptoms, sleep disturbances are going to be the most common ones we're going to hit on today. And then really a big part of our management comes when we really engage the caregiver. I have found that my caregivers are my greatest teachers. And if I can spend even just 5 minutes helping engage them and empower them, then oftentimes my job goes down on the list of importance, and also my portal inbox gets lower and all of that. And so we'll talk a little bit about that if we have time at the end. Next slide, please. So this slide goes to really explain the complexity of what it looks like to manage dementia symptoms, especially from a pharmacologic standpoint. So we walk in the room and we see a patient, and we look down and we might find their med list, which is here in this bottom corner in the blue, and realize that this person has seen several providers over the years. Maybe they've all heard about this person's sleep disturbance and agitation and delusions and put them on multiple medications. And we're running into polypharmacy quite often, especially in the geriatric population. And so quite often you're encountering someone who's not naive to drugs for their symptoms, and they may be put on multiple medications that may or may not play well with what else they have going on. In addition to that, you find that this woman here is not me as a haggard mom running around taking care of my children. It's actually a dementia caregiver who is doing all the things while also still trying to support her spouse or mother or father in the care of their day-to-day lives. And she can't be their medical provider and their cook and their housekeeper and all of that, while also being a cruise director. And so this person really does find themselves quite stressed out, and yet we often encounter situations in the clinical setting where that person may be hesitant to speak in front of their loved one as well. And so you've got the complexities of how to communicate and actually get the information you need about what's going on with that patient, with care partners and patients themselves who may be very stressed and anxious. This top box here really speaks to the fact that when you look at any study about agents, pharmacologic agents to treat things like depression and delusions and agitation and dementia, they all say, well, none of them really work, but you can try. And that can be quite frustrating as a clinician as well, as you wonder, is this safe? Should I be trying it? Does it even work? And yet, with the time we have teaching non-pharmacologic strategies and trusting this stressed out caregiver to be able to really follow through on that perfect schedule that their loved one needs to be able to get good sleep and be less agitated and be socially and mentally stimulated can be quite challenging. And finally, there's that ever-present black box warning that if you give these patients risperidol or Seroquel, they're likely to die from a stroke or heart attack. And so we have these layers of concern as clinicians on how to really address these symptoms. Next slide, please. As we talk about these symptoms, they really emerge in different ways depending on stage. And then I would argue that they also emerge differently depending on the patient's level of awareness of their own symptoms. My patients, like the one I saw this morning with severe anosognosia or lack of awareness of their symptoms, present a much greater challenge clinically managing them and their symptoms, because they often are not aware of their cognitive symptoms, first of all, but they're also not able to necessarily speak to you about sleep disturbance and other things. And so early in disease, we often see patients who are more aware of their symptoms, and they may self-report depression, anxiety, sleep disturbance. Their care partner may on the outside looking in observe some apathy and withdrawal, because this person was likely previously a more productive person in their society, whether they're working or retired, but actively engaged in things. And they may see more withdrawal and apathy as the disease progresses and be concerned about that, along with some symptoms of depression, anxiety, and sleep disturbance. Delusions and hallucination are less common at this stage of disease. And yet if your patient has underlying Lewy body pathology, then they may actually present early with hallucinations specifically. In middle stages, we start to see, and I call this the long, hard phase of the disease. A lot of my families come in at middle stages and say they've fallen off the cliff. Everything's so much worse all of a sudden. And typically, if you do a good history, it's not all of a sudden. It's just that the care partner burden has gone up so much in this stage. As things like delusions, hallucinations, paranoia, more agitation start to emerge, along with sleep disturbance. A caregiver that's not sleeping is a stressed caregiver. And so this emerges a lot in middle stages of disease. And then anxiety and depression can persist or emerge. Sometimes it can be hard to distinguish that though from their dementia symptoms. So we'll talk more about that in a few minutes. In later stages, either the neuropsychiatric features decrease or they change in nature as patients lose ability to communicate. So it can sometimes be hard to know if the person's actually hallucinating, but they will let you know if they're not really wanting you to rip their clothes off and stick them in the shower and show some resistance to care and agitation and feel some paranoia there. And so tweaking out those symptoms can be a little harder in later stages. Sleep disturbance often looks a little different. There may be nighttime wandering more in later stages as the disease progresses really, and they're bedbound. There may be much more excessive sleep as well, which may or may not be something that needs addressing. And then finally, depression and anxiety may also take a different flavor as people lose verbal communication abilities. So irritability, pacing and repetitive behaviors, appetite changes, or frequent crying may be things that we need to look at that may represent underlying depression, anxiety in late stages, even if the patient's not telling you they're depressed. Next slide, please. All right, we're going to have some more fun typing in the chat. So I want you guys to think about anxiety and depression in your dementia patients. And if this is something that you do for a living and you do treat patients by selecting and managing antidepressants, how comfortable are you with selecting and managing antidepressant medications for patients with dementia? 1 being not at all comfortable, 5 being very comfortable. Go ahead and drop that number in the chat if you don't mind, and we'll take a look and see what's coming up. We've got a 5 and a 3. My hunch would be it's kind of all over the board. So appreciate everybody throwing out those numbers there. I want to dive in a little bit on anxiety and depression. It looks like most people are fairly comfortable, but there's plenty of us that can find that to be a bit of a daunting task. So next slide, please. Go ahead and progress to the next slide. All right, perfect. So as I mentioned earlier, it's sometimes hard to tweak out if a patient is actually depressed or anxious, or if these are just symptoms of their depression. So for example, if I have a family member, a care partner come in and say, you know, every time I bring up the subject of driving, my husband's super irritable and I just don't know if I can handle it anymore. And he tends to, you know, have a little trouble falling asleep at night. That may be normal irritability over the fact that the care partner is bringing up driving quite a bit and that person can't drive anymore. That person may have had somewhat of a change in their activity during the day. And so they're having more trouble falling asleep because they're napping in the day. And it may be hard to know if that's depression. What I often tell people in trying to tweak out depression and anxiety from just dementia symptoms, or apathy is a big one where it's hard to know, hey, dad doesn't talk at dinner as much anymore. Is that depression or is it just his dementia presenting itself? Is I really try to get at frequency. Is that person irritable most of the time? Do most subjects bring out some form of irritability and reactivity? Is it several days a week that you're finding yourself in a place of being concerned about that person's mood? Are their sleep habits altered most of the time or just on occasion? And then I also get a sense of caregiver coping skills and whether or not some of that agitation that we're seeing has more to do with the communication that's going on in the household than the person themselves having true agitation and irritability. With apathy, does structure and routine help? Does the person seem to look forward to going to their grandkids' games, or do you have to pull them out of the house to really get them to do things? And so some of those questions will really get at whether or not this is depression or dementia or both. There's really few studies to guide selection of antidepressant medications in dementia, but it's still pretty much considered that SSRIs are the preferred starting point. Everybody tends to have their favorites. I have found that side effect profiles seem to be most tolerable with both escitalopram and citalopram, or Lexapro and Celexa, and that they tend to work pretty well with pretty much all comer symptoms. And so it's a good starting point. Sertraline is often helpful and is used quite often in older adults. I use it a lot for patients who have more repetitive or obsessive type behaviors and who don't need much activation. For those that need a little more activation, who are pretty blah and need some energy and activation, fluoxetine can be a good option. It does have a longer half-life and some side effect concerns. Second line would be something like an Effexor or bupropion. I often tell people that if they're naive to any sort of antidepressant regimen or anti-anxiety, that an SSRI is a great place to start. And once we've titrated up to a therapeutic dose and had someone on it for at least a month or two, preferably 2 months or so, and we're not seeing improvement, then we might consider a switch to a venlafaxine or a bupropion. Paroxetine is really the only SSRI that we have concerns about in the dementia population in terms of major side effects, and the anticholinergic properties there can be more problematic in our patients. And so I really avoid paroxetine at all costs, and will often take someone off of it if they come to me and they have a dementia diagnosis. We're going to move on to our next topic, which is to deal with neuropsychiatric symptoms in this population. And I want you to imagine a patient who's otherwise healthy. Maybe this lady takes one drug for hypertension and is on a vitamin D, but otherwise doesn't take medications regularly. She's generally been healthy. She has Alzheimer's disease and is now entering the middle stages. And her husband calls to tell you or send you a portal message that she has suddenly become in the evenings very agitated, has started to believe that there's people in the yard that are trying to get in the house. And she's quite fearful and has even called the police on a few occasions. So she's having some hallucinations. She's having some delusions. So in this otherwise healthy patient with dementia who's now having a new onset of delusions and hallucinations, which antipsychotic would you be most likely to prescribe as a first-line treatment if you did decide to prescribe an antipsychotic? And you can even say, I'm not comfortable prescribing antipsychotics. That's a perfectly acceptable answer as well. So go ahead and drop your answer in the chat on that. All right, I've got Sarah Quill from Seth Stefka. Dr. Cohen's wise, and she's going to do a delirium workup first. I've got some not comfortables, another Sarah Quill. Fantastic. You guys can continue to drop those in the chat as we move on to the next slide. And we'll talk a little bit about that. So as we know, neuropsychiatric and behavioral symptoms of dementia do commonly occur. And as we mentioned earlier, we start to see them emerge quite often in middle stages of disease. It can be anything from agitation, or if you can go back a slide for me there, Ted, anything from agitation to delusions, to hallucinations, to paranoia, but they're often underreported. Or what you can sometimes find is that the care partner won't report them until it's really in crisis mode. And so I can't tell you how many times I've gotten a call or a message that we're so hyped up now that the caregiver doesn't feel safe, or the person's about to leave the house, or they've become aggressive, and it's at a point where we're concerned about safety and hospitalization. And so what I really love to do is try to ask about these symptoms early before they escalate to a point of crisis mode, so that we can intervene early. More often than not, a good history will tell you what you need to know. And so you need to better understand the symptoms they're presenting with. as well as identifying an underlying cause. So as Dr. Cohen wisely pointed out, I really never throw a medication at a patient with neuropsychiatric symptoms until I've understood if there's an underlying cause. And so a delirium workup, by seeing the patient and checking for any signs of illness, urinary tract infection, dehydration, so on and so forth, will really get you a long way, as well as looking at their medication list. What we often forget to ask about are things like over-the-counter medications. It's allergy season. Are they suddenly taking a Benadryl every night to try to ward off the pollen? Or are they now, taking a sleep aid that they tried from the pharmacy? And so over-the-counter drugs, new medications that were started by a referring provider that we don't know about, changes in medication timing can all be significant, as well as mixtures of medications. Believe it or not, I have had many patients who we put on a drug like memantine trying to help their cognitive symptoms get more confused or more agitated. And so you want to ask about new medications as well that might have some paradoxical effects that we don't want. And then the other thing that I always remind providers of is to make sure that you assess for the impact of quality of life before treating, and to assess whether or not caregivers are well resourced in terms of how to deal with some of these symptoms. And so I have had patients with hallucinations that find them to be perfectly pleasant. We had a woman who had a chamber orchestra that would play in her room every afternoon, and she said, please don't get rid of that. It's lovely. That's rare. But we do have plenty of patients, especially with Lewy body dementia, who, when told that their hallucinations are a part of their disease, feel much more at peace about them and can name them and move on. And so they don't always require treatment, especially if you have a good care partner who knows how to reassure and redirect the person. I have plenty of patients who blame their symptoms on Lewy and laugh about it and can move on. And so coaching families through that and normalizing some of it can be helpful as well when it's not really impacting their quality of life. However, if pharmacologic treatment is indicated, I often start with a cholinesterase inhibitor like Aricept, donepezil, or rivastigmine patch if they're not going to tolerate an oral formulation. Galantamine is another one that's not commonly used, but it works just as well. Its efficacy is on par with the others. And I sometimes will switch people to galantamine if they had tolerability issues in terms of vivid dreams or GI with donepezil, but they can't use a patch. So those three are all equally going to be potentially effective both at treating cognitive symptoms, but there's a good bit of evidence in the literature that they will help with behavioral symptoms as well. If they're already on a cholinesterase inhibitor and they're having these emerging symptoms and they're more towards middle stage disease or late stage disease, we can consider adding memantine as well. But I put a star there because, again, I always remind my patients that in a very small percentage, we will sometimes find increased confusion or depression and agitation with memantine. And so my rule of thumb for them is if they get more agitated rather than less, or more confused rather than less, call me and stop the memantine. But in many patients, it does seem to provide some benefit to their mood symptoms and their behavioral symptoms. And SSRI is also a good option, it's especially useful, the literature says, in agitation and paranoia. And if I do feel like it's kind of a low-lying agitation, or they're just a little bit paranoid and it has more of a cognitive paranoia flavor than it does this true, I think there's someone breaking in my house to kill me, then I will sometimes try an SSRI before I try something more intense. Next slide, please. Mood stabilizers can be an option. I do this only when other things have failed or the person is really labile and agitated and aggressive. Lamotrigine is typically our first choice because of the more favorable side effect profile, although you really want to be careful with slowly titrating that, and recognize that it's also not going to act very quickly at addressing symptoms. I've used Depakote, but I've also seen patients on Depakote who come back to me stooped and drooling and Parkinsonian. So we want to be really careful with that. Atypical antipsychotics, as we mentioned very early with my question about the chat, can be indicated. They are used in my practice. I use them if it's really critical to patient and caregiver safety, to their well-being and quality of life. And we've gone through all these other things about coaching on how to deal with them and normalizing it and trying to rule out delirium and other medications that might contribute. We really do want to have conversations about this FDA black box warning. The black box warning is difficult. When you study a drug in young patients with schizophrenia and give that same drug to 70 and 80-year-olds with dementia, you are going to have a higher rate of stroke and heart attack. And so whether that's because of the patient population that we had that higher risk there, or whether it really has to do with drug is still a bit unclear. And I say that to my patients. However, I also use a lot of caution and reassure them that I am never here to sedate your family member. And I certainly want to keep their well-being at foremost in my mind. And certainly if they have underlying cardiac conditions that would make us concerned about using antipsychotics, we'd be even more cautious. Seroquel is my go-to, or quetiapine. It is the weakest antipsychotic, which may sound like a thumbs down, but in our patients, something that's slightly weaker and has a more favorable side effect profile, maybe all you need, a 25 milligram of quetiapine at bedtime, and a 85-year-old woman with dementia who weighs 130 pounds soaking wet may be a good choice. And it may quiet some of her delusions, give her a good quality of life, and especially if she also has sleep difficulties, may be exactly what you need. I can honestly say in 13 years of practice that I don't know that I've seen quetiapine cause much Parkinsonism in any of my patients. And so I really like it for that reason, because we worry a little bit less about falls. But we certainly want to be cautious. There's a larger dosing range as well. So you can start at 25, and the higher end of that is 300, which I have only one patient on ever, but still you want to be careful. Olanzapine and Zyprexa, olanzapine or Zyprexa risperidone may be indicated if there's more severe symptoms, but again, you want to be cautious with symptoms, with side effects. And I have not used the newer pimavanserin or Nuplazid, which is FDA approved for Parkinson's disease psychosis. It's very hard to get in terms of price, and I have had mixed results with that, but it is an option out there if you're running out of options. All right, next slide. All right, sleep disturbance is the last one I want to hit on. How often do you encounter complaints of sleep disturbance in your patients with dementia? You can go ahead and drop that in the chat for sake of time. I'm going to move on. So not very often, all the way to very often, let us know. I know early on we had a lot of people answer that it's pretty common in your practice, or maybe the most common thing that you see. It's really important to address because of the impact on caregiver distress. As I mentioned earlier, a caregiver that doesn't sleep is not a happy caregiver. It's associated with an increased likelihood of institutionalization, and it can have implications for progression and prognosis. There are studies out there that show up to a 30% increase in dementia risk in patients who've had poor sleep for most of their life, along with a much higher risk of death and progression of their dementia symptoms. You can read here the common presenting symptoms. We deal with anything from difficulty falling or staying asleep to sleep apnea, which can really increase your cognitive risk of getting some cognitive symptoms getting worse, daytime sleepiness. And then in our patients who have coexisting Parkinson's-like diseases like Lewy body, we see a lot of REM behavior disorder, acting out of dreams at night, and restless legs and periodic limb movements. Again, this by all means is one of the areas where you want to focus on non-pharmacologic options first. And yet that can also be very challenging in a patient population where you've got that stressed out caregiver that we saw at the beginning, who also needs to be a cruise director. Getting patients engaged in things like adult day programs can really help with their daytime activities, and it isn't putting as much stress on the caregiver, and allows them to really use their time and energy in the daytime so that they can sleep better at night. Polypharmacy is a huge concern with sleep, and there are several medications that can really impact sleep. Moving timing of medications, donepezil is notorious for causing vivid dreams and sleep disturbance, so moving that to the morning will often fix a lot of things in my patients that I broke because I put them on donepezil. So timing of medications, diuretics, things like that, moving those to the morning can help as well. Next screen as well. I see this a lot. A lot of folks use antihistamines, antidepressants, anticonvulsants, and antipsychotics like quetiapine to treat insomnia. There is no evidence that these are effective or indicated for sleep. Now, if the person has sleep disturbance and they're psychotic, then maybe it makes sense. But as a primary agent for insomnia, they should not be used. I have started using melatonin more. There's some recent studies about concerns about concentrations of melatonin in over the counter, so you have to be careful with that. And if people have questions about brands that I commonly recommend, I ask my sleep medicine folks and they gave me a few, so I'd be happy to share those. But you can titrate that up to 10 milligrams. you just want to watch for patients who tend to have a kind of hangover effect with melatonin the next day. Trazodone is one I use commonly, especially in my agitated and sleepy patients. And then mirtazapine is a 3 birds with 1 stone medication for patients who are having trouble with appetite, sleep, and mood. So those can be good options as well. Sleep apnea is important to treat if identified for the reasons I mentioned earlier in terms of impact on cognition. And then finally, our dopamine agonists like propranolol can be helpful for restless leg and periodic limb movement disorder, melatonin, or low-dose clonazepam. Clonazepam in REM sleep behavior disorder is about the only time I'll use a benzodiazepine in older adults. So that can be an option, especially if they're having injurious behaviors and falling out of bed or beating up their care partner. All right, I think I may have a minute to hit on care partner considerations. As I mentioned earlier, they really are the other patient in the room. The thing that we struggle with is getting information. And now with virtual, I found my caregivers sit over on the side and I can't see their faces anymore. I love to have my care partner sit next to or, but near their loved ones so that I can watch their reactions to things. And then I also try to normalize the discussion. I likely will say to my patients when I walk in the room, I'd love to hear from everyone and I'll believe all of you. Because it really is a helpful way of saying, we all have different perspectives on your sleep, on your mood, and all of that. And we try to use humor just to try to make everyone comfortable with talking openly about what's going on and what the care partner sees versus what their loved one sees. And that can be difficult, but it can really go a long way in eliciting the history you need if you can talk to the care partner separately, or if you can have a clinic flow that allows them to send you a portal message ahead of time, that can be really helpful as well. And the last thing I'll share is that empowering caregivers with some great tips can really go a long way. And so you can look at this beautiful little QR code that Dr. Johnson plugged in there for me to go to UCSF's caregiving site. What I like about it, and here's a little clip from it over on the side, is that you can click on a behavior or a symptom and it'll tell you an if and then a then what to do. So if they're acting socially inappropriate, here's some things you might try. And so it has a really good practical approach to caregiver management. And then you can read here my basic rules for caregiver communication. I tell them that their loved one is always right unless it's a matter of safety and not to argue. And that reassuring and redirecting by going out of the room to run to the restroom and coming back with a big old bowl of ice cream can often be the best cure for any sort of agitation or delusion that a patient is having. So having some fun with it, but also really helping them stay on track with the fact that we're living their truth, not ours, and orienting to our own reality often doesn't work, can go a long way in helping folks. So I am 1 minute over time, so I'm going to stop, but I really appreciate you guys taking time to join me today, and I'm always available for questions afterwards if anybody has them.
Stephanie, thanks so much. That was super. We really appreciated it. If you have the chance to offer a survey response for us, I'm going to copy and paste this link in case you are just pulling things out of the chat. But if you wanted to use your phone and the QR code there, you can also do that. So again, thanks so much for joining us today. We really appreciate your participation and engagement, and let us know how we can be of help. We do post these videos. Oops, sorry. Let me just do, I'm trying to multitask. Let me see if I can do everything at once here. So sorry, go ahead and take a picture of the QR code. And thanks so much, Stephanie. We really appreciate you. You did provide some references for us, and so we'll work on getting those in a form where you can download them from our website. Any quick questions that folks have? Joanna, thank you for sending the survey link. I appreciate you. Any questions for Stephanie? Any comments? Feel free to put anything in the chat that you wanted to bring up, or anything that you'd like to ask Stephanie. Just come off of mute.
Yeah, I'm here for a few minutes before I have to roller skate over to clinic again. So feel free to throw some questions out there. Thank you, guys.
Thumbs up for you, Stephanie. Really appreciate it. Thanks so much, everybody, for attending.
Thanks, guys.
And we'll see you next time. Thanks
Be well.
again.
Bye-bye. Thank you.